I wanted to show some early results. One is the amount of face-to-face visits, which is the black line, versus the purple line, which is the email encounters. So we really used emailing to help. And it turns out that patients actually don't always want to see their doctor. That, you know, they can have their needs addressed through email and phone messaging. So we really made it part of our day. Again, proactive management. This is knowing who your patients are, what their needs are. One of the important aspects of this model is that you want to engage the patient in deciding their own goals. And that's, again, more important than you think. Patients, you know, the traditional model is you go to your orthopedist with your bum knee and they say, knock off 10 pounds. And we know as family physicians, that's just not going to happen for patients. So again, it's establishing that rapport, working with people to identify what their actual goal is. Now this is what you need for a medical home. I wanted to revise maybe that second one, which is the electronic medical record. That's enormously helpful in terms of having registries so that you know who your patients are. But there are practices out there that simply can't afford an electronic medical record, and you can still do a model like this. It's a little harder. And then I basically wanted to go back and then give you some data. So we measured, we did some measurements, and this is not my department, but there were several scales that we measured patient satisfaction and clinical satisfaction. One is this ACEs and the PACIC. And there are probably people out there that know what this really is. The ACE measures shared decision-making, coordination of care. These were the questions we asked the patients. Helpfulness of the staff, quality of the doctor-patient interaction. The PAC, again, was talking about did patients feel involved in their goal setting? And then some of the other aspects of chronic care. What were the results? We found that emergency room visits from our clinic, and this is a bit of a confusing slide, it isn't that they were 29% lower. They were 29% lower than the 2 control clinics from before. So there was a real drop-off in emergency room visits for our patients. We had 6% fewer face-to-face visits. That meant we had more time with patients. We had 30 minutes, which is phenomenal. But we were doing a lot of other touches, phoning, email, very important. We found that hospital admissions did not change, but there was a trend towards the ambulatory care sensitive cases. And then finally we measured with something called the MASLAC burnout inventory. And I think that's an inventory that they do with airplane companies and talking to people. And we did a before and after study for clinical staff burnout. So the upshot was this model was cost neutral. It meant involving primary care, or investing more money in primary care. But it resulted in real cost savings in terms of redundant emergency room medicine. We had dramatic patient response. They liked this model. They liked having the extra time. They liked the access. And finally, we had lower staff burnout. And this may not seem like a big deal, but this country is losing its primary care doctors. They've got the message. The money's out there is in dermatology. And family medicine is hard work, but it's incredibly rewarding. So, and as a final thing, we could show that the HEDIS measurements really improved. And so our clinic has become the leader in the group health system of all these measurements. So I'd like to thank you very much.